HighBridge, a division of Recorded Books, presents Making Tough Decisions About End-of-Life Care in Dementia, a 36-hour daybook by Anne Kenny, read by Randye Kaye. Preface. This book is laid out as a guidebook. Nearly 500,000 individuals are diagnosed with dementia every year, year after year. As stunning as that figure is, it does not take into account the family members and caregivers who are subsequently affected by each diagnosis. When they are included, the numbers rise to an even more incredible level. What this means in our society is a rapidly ballooning population of people faced with painful scenarios and the need to make vital end-of-life decisions for those who no longer can, a role for which most are largely unprepared. Sadness, confusion, guilt, anger, and physical and mental exhaustion become the norm for these families as the disease enters its final stage. The toughest decisions I ever made were about the life and death of my mother, who had lost her voice in decisions to dementia. But I was one of the lucky ones. My 25 years as a doctor specializing in the care of older people and end-of-life care had prepared me to face these decisions. Yet, even with that advantage, I struggled. The challenges that dementia and end-of-life decisions present usually are overwhelming. My personal experience compelled me to fuse my clinical knowledge with everything I learned helping to care for my mother into a book to help others. This book is a guide focused on care and decisions in the final stages of dementia. Specifically, it is meant to help you deal with inevitable end-of-life problems, such as pain and difficulties with eating, and show you how to navigate the difficult decision-making challenges and communication needs among caregivers and healthcare providers in the final stages. The guide may be heard as a whole to give you a landscape for what types of decisions and issues surrounding care and communication may arise along the journey with dementia. Also, if you have questions about care issues specific to the end stage of dementia, you can review the relevant chapter. For example, many families want to know more about what happens in the final weeks or days of life to prepare themselves or other family members. This can be found in Chapter 7. Each chapter includes stories of families I've met and worked with during the past 30 years. These stories are meant to illustrate a common issue, concern, or situation that occurs in late-stage dementia. I hope that by seeing how others have met these challenges, you will see a way to go forward also. The names of all the people involved have been changed, identifying characteristics such as ages, genders, ethnicities, professions, familial relationships, medical situations, and social situations have been changed to protect the identities of those involved. At times, a composite of a few people or families was created to illustrate a point. Any resemblance to persons, living or dead, resulting from these changes is coincidental and unintentional. Introduction. Beginning the process of letting go. The Kenny family story. The time had come. I had seen it coming. My sister called to let me know my mother had been admitted to the hospital for the second time in 10 days. The call signaled the change in my mother I had been both waiting for and dreading. Once a vibrant, laughing life of the party, my mother had become quiet, tentative, almost shy. She had always been known for her laughing eyes, her love of song and dance, and her playful spirit. When one of her 6 children needed discipline, with a twinkle in her eye she would threaten to hit us with a board, quickly upping the ante to a board with a nail, followed by a board with a rusty nail if we kept up our antics. We never met the end of that board, with or without the nail, although she had our attention as she reprimanded us with love and tenderness. But now she was distant and reserved. Her usual sparkle was lost, replaced by a look of fright or uncertainty. She had our attention again. The changes signaled the late stages of her 10-year journey with dementia. She lay in the hospital bed, ignoring her limp right side. A lopsided smile, when she could muster one on her mostly sad face, was too often punctuated by flashes of anger as she attempted to make herself understood but could not come up with any words, or worse yet, the wrong ones. These changes had been brought on by a stroke that took even more of her memory, personality, speech, and strength. In the last year or so, my mother had begun the process of letting go. She was letting go of her loves, travel, her home, her husband, her independence, her twinkling eyes. Conversations about death and letting go. As a geriatrician and palliative care physician with more than 25 years of experience, my goal is to help families give a voice to the person whose voice has been lost to late-stage dementia. Luckily, some have had the conversation about how they would like to live through to the end of their disease during the early stages when their voices were strong and clear, making letting go easier for their families. But many others avoid the conversation because discussing death and the process of dying is uncomfortable and, to some, taboo. Even those who waded into the waters of discussion of facing death likely did not reach the level of detail needed by families as they grapple with the day-to-day decisions when dementia has progressed to the late stages. Decisions about when to feed or not, when to give antibiotics or not, when to stay at home rather than being transferred to the hospital. Making decisions yet even more difficult is the possibility of pushback from healthcare providers who reflexively maintain life and are often most uncomfortable addressing death. Finally, it does not help anyone facing these choices that dementia is accompanied by a variable and unpredictable decline. Persons living with cancer, who usually maintain their voice, are pioneers in training healthcare providers in the possibility of honoring a less medicalized version of the end of life. There are lessons to learn from death, the ability to see death as a liberation and a time for growth, rather than resisting its inevitability with tubes, wires, and machines. The time has come to offer the same holistic approach to those living and dying with Alzheimer's disease and related dementias. Resisting the progression of disease. Teresa's story. Teresa's small cherub's face, along with her white hair and smooth skin, hid her chronological age. She was in her early 90s and, for the first time since I met her, sat with her shoulders slumped. She had buried her lifelong love, Herb, 3 months earlier. Herb had lived with dementia for 8 years, 6 years active and engaged, 2 years in bed and withdrawn. I had shared in Herb's care for about 6.5 years, but then Teresa and Herb's children requested to continue Herb's care with another physician. They felt that Herb's decrease in activity and mobility, along with his weight loss, should be aggressively challenged. Teresa was caught between what I described as the progression of dementia and the desire to follow the advice of her children and the hope that they were right and that Herb would perk up with physical therapy, aggressive nutrition, and stimulation. Teresa was reliving with me Herb's course since I had last seen him 18 months earlier. She described exhaustion from transferring Herb into and out of a wheelchair to get him to physical therapy 3 times a week, from cooking 6 meals a day, from constantly coaxing him to eat a few bites. Herb would often have angry outbursts when she woke him to eat, move, or talk. She poked and prodded him to lure him back to life. After about a year, she heard a small voice telling her she was not helping either Herb or herself. As she began to relax, Herb rested, and she did too. But then her children started up. "Why isn't he eating? He's losing too much weight. He can't even help us when we try to walk him to the bathroom anymore." The children took turns living with Herb and Teresa to help with the eating, exercise, and stimulation. When Herb died in the hospital from complications of a urinary tract infection, Teresa said the entire family was exhausted and angry, questioning what else they could have done. There was no peace or acceptance of death. Dementia is a chronic but terminal disease, no matter how much care we give. Is there another way? I spoke with a new friend who had spent 11 years caring for her husband. She now works to assist others in coping with care partnering because she doesn't want others to have to learn by trial and error what she had to learn and come to accept on her own during her time as a care partner. She said that even with all she learned, she thought she could keep her husband from dying. She felt her care partnering and caregiving would protect him from death and from leaving her. She says she finds this sentiment to be true in many of her caregiving support groups. She now tries to ease the groups into understanding that there is a time that we will die, even from dementia. Dementia, the sixth leading cause of death in the United States, has different stages, the early and mid stages in which individuals continue to participate in many of their typical activities, and the late stages with the hallmarks of severe disability. The typical features of advanced dementia are profound memory deficits, limited verbal abilities, impaired ability to walk independently, and loss of the ability to perform activities of daily living, for example, bathing, dressing, and toileting. At this stage of dementia, life expectancy is typically only a little more than a year. Most individuals have difficulty eating, their swallowing muscles forgetting the steps to chew, swallow, and protect their breathing tube. The result is pneumonia, often repeated bouts from aspiration. In studies done by investigators at Harvard Medical School, 90% of those making decisions for individuals with advanced dementia state their goal is for comfort, moving away from goals for treatment or cure. Yet, approximately 16% of those who die with dementia do so in the hospital, and reports show that 20% of those with dementia have multiple transitions or hospitalizations in the last 90 days of life. Shifting focus from cure to comfort, Mary and Ted's story. When I first spoke with Mary, a petite woman with warm, deep brown eyes, she never took her hand off Ted. Ted was long, lean, and asleep, but with the droopy, drooling face that accompanies over-sedation. Ted's wrists were restrained, and an intravenous line snaked into his left arm, an arm wrapped above and below the elbow onto a thin, padded board designed to keep his arm from bending and kinking the intravenous tubing. The sheets had been kicked off his legs, and I could see a catheter in place so that Ted did not urinate into the bed. Mary looked embarrassed as I quickly scanned the room and the situation. I'm afraid to move the sheets or speak too loudly for fear of waking him and having him yank at all his tubes. He just finally settled down. He gets so angry and afraid. He just thrashes around. The thrashing scares me. It's bad enough at home when he gets upset, but here he is connected to all these wires and gizmos. I know he would be appalled at being in the bed without being covered. Her eyes well with tears. I just never know whether to bring him here for this. She motions at the intravenous bag, the hospital room, and Ted tied to the bed. Or what would happen if we just stayed home? After Mary spoke a little longer about her and Ted's 45 years of marriage, their children, and their life, I began to bring the conversation back to Ted, his diagnosis, his stage of dementia, the reasons for bringing him into the hospital over the last year, and her initial query, what would happen if they just stayed home? Ted had reached the final stage of dementia. He was sleeping 14 to 16 hours a day and had lost his ability to speak. Mary described only short periods of meaningful interaction. Whenever Ted's behavior changed, he would become more aggressive or sometimes sedate. Mary knew healthcare providers would find a urinary tract infection or pneumonia. I discussed with Mary the usual course for dementia in the late stages. It is a relief to hear from someone that this is the typical situation. No one has ever talked about what happens as the disease gets worse. I always think I haven't taken good enough care of Ted, and that is why he is declining. We discussed what would happen if they stayed home the next time he was sick. But how can I not treat something that is fixable? It is the question I'm asked most often, and the reason for this book. How we see death and how our visions are changing. National conversations about dying are beginning. In Being Mortal, Dr. Atul Gawande, a surgeon at the Brigham and Women's Hospital in Boston, Massachusetts, and frequent contributor to The New Yorker, explores our national and cultural medicalized dealing with aging, frailty, and death. Dr. Gawande posits that we may want to bring meaning and well-being back to the forefront rather than survival and safety. I now have people talking with me at parties and barbecues about the concept of allowing death, conversations that did not happen 10 years ago. Michael Hebb, described as an innovative and influential cultural figure, entrepreneur, and activist who uses food and the dinner table to provoke discussions and connections, began the Let's Have Dinner and Talk About Death movement, an idea that came to him as he was commuting on a train, discussing the state of healthcare in the United States with two other travelers, both physicians. He learned on that trip that although 75% of individuals would like to die at home, only 25% do. He also learned that a staggering majority of bankruptcies are due to end-of-life healthcare costs. He personally admits that one of his only regrets is not spending more time with his father during his final years, living with and dying from Alzheimer's dementia. In April 2016, Hebb estimated that about 10,000 death-over-dinner events had occurred in 30 countries. The website deathoverdinner.org describes how to host an event, with supporting materials to choose from to personalize how to enhance reflection, introspection, and conversation. Those involved in these dinners find that speaking of death can be moving, cathartic, warm, and liberating. You may find that having the courage to start such a discussion with prompts suggested by Hebb, including good food and maybe libations, will lead to some interesting and surprising insights and revelations. Other movements such as 5 Wishes, Compassion and Choices, and the Conversation Project move discussions forward to understand and deliberate advanced directives and articulate choices and wishes for the end of life. Physicians and other healthcare workers are not currently trained to think about letting go, but this is changing. The John A. Hartford Foundation, an organization dedicated to improving the care of older adults, released information that only 29% of primary care physicians received training in end-of-life discussions, although nearly all believed that this type of physician-patient discussion should occur. The introduction of Vital Talks, a program geared to healthcare providers to aid in the how to have difficult conversations in palliative care, is spurring spin-offs specific to oncology, emergency medicine, and other specialties. All these efforts by the healthcare community are a good beginning, but they may not reach your neighborhood in time for you and your family. In the hospital where I work, I know I will be in a meeting with family members, hospitalists, and other specialists, and no one will be directly talking about the process of dying. When it is finally brought up, the entire room seems somehow to physically relax. Shoulders lower and faces soften, and we can begin the real conversation that we know we are there for. The conversation may have sad elements, but the need for the conversation is real, and the situation is often better dealt with directly. Recognizing that direction may not come from the healthcare community. Dr. Kaye. I was approached by the nursing supervisor, Tessa, from the medical floor, asking if she could speak to me in a small conference room. She pulled up a chair and sighed, and then leaned in close and said, "Can you please talk with Dr. Kaye? We all know she hates to see someone die, but this is getting ridiculous. The family wants to take Mr. Jacques in room 23 home to die, but she is pressuring them to get a feeding tube, at least for a 3-month trial." Tessa described Mr. Jacques as being in the late stages of dementia. He'd been admitted every month for the last 6 months with a range of maladies, including urinary tract infection, influenza, and dehydration. He was losing weight, awake for only a few hours every day, and in no need of medications. His children had all come together to assure Mrs. Jacques that further medical treatment was not necessary to keep Dad alive. They wanted to support their mother in whatever decision she felt was right for her husband. Once Mrs. Jacques knew her children supported her, she admitted she felt the last year or so had been torture for her husband, and it was time to stay home and keep him comfortable. No more back and forth to the hospital. Dr. Kaye was asked to come to a family meeting to hear this decision, but she told the family that because most of his admissions were for dehydration, he could be kept hydrated at home with a feeding tube. The family reacted with anger and confusion and asked Dr. Kaye to leave so they could discuss the new information among themselves. Mrs. Jacques held her face in her hands and cried. She did not want to give up on her husband if there was a chance for improved quality of life, but the mixed messages from the medical community confused her. I approached Dr. Kaye and asked what her understanding was of Mr. Jacques' condition, prognosis, and goals of care. Her eyes flashed angrily and then quickly looked away. He just can't keep up his hydration. A feeding tube seems the best course of action. I asked, for what outcome was it the best course? So he can live. She emphasized the last word very heavily. I sat quietly for a minute, waiting to see if she had anything else to say. Dr. Kaye began to cry, softly and quietly. She whispered, "It just gets so hard to see all these people die. I just want to do something to help them." I continued to wait. "I can't just offer nothing." I asked, "Is that what you think? That you have nothing to offer?" Dr. Kaye nodded and asked, "Don't you?" I said, "There is so much to offer, compassion, an ear, an opinion, and understanding." Dr. Kaye said, "It doesn't seem enough." Healthcare providers are trained to prevent mortality. Dr. Randye, in Being Mortal, describes the medical profession as one that sees a problem and then fixes it, but with aging, frailty, and dementia, there are no real fixes, thus leading to suffering rather than comfort. This experiment of making mortality a medical experience is just decades old. It is young, and the evidence is it is failing. Our reluctance to honestly examine the experience of aging and dying has increased the harm we inflict on people and denied them the basic comforts they most need. My goal in this book is to assist families in understanding the current focus of society and healthcare on preventing mortality. From this understanding, families will be better able to advocate with healthcare professionals to obtain the best care for a family member who is in the end stages of dementia. The conversation, led by those with the needs of their family at the center, will expand to include other decision-makers, family members, physicians, long-term care administrators, and staff for day-to-day decisions. In time, the conversation needs to extend to legislators and cultural leaders who articulate the thoughts of the country. A palliative approach to care at the end of life for those living with dementia means shifting our perspective to focus on goals of connection and comfort and away from procedures, hospitals, and life at all costs. Points to remember. Discussions regarding death from dementia are not happening among family members, healthcare workers, and the community. The lack of understanding and discussion about signs and symptoms that signal late-stage dementia may contribute to the lack of conversations regarding wishes for end-of-life care in family members with dementia. Those living with late-stage dementia often are subjected to multiple hospitalizations and medical procedures when reports suggest those who make decisions for them or surrogate decision-makers favor comfort. A national dialogue on accepting death into the medical model of disease is taking root, so that more families and healthcare providers are making decisions that focus on connection and comfort rather than on prolonging survival at the end of life, such as during late-stage dementia. Action Plan. Be brave enough to begin conversations about death and about you and your family's wishes for how to die using one of several platforms described in the text, such as Death Over Dinner or the Conversation Project. Educate yourself about the signs and symptoms of the last stage of dementia so you are ready to deliberate the right course of action based on the prognosis in late stages. If your family chooses comfort rather than a curative approach, seek out the assistance of a palliative care team that focuses on a holistic approach to navigate the healthcare system for your family member. Additional reading and resources. Embracing Our Mortality: Hard Choices in an Age of Medical Miracles by Lawrence J. Schneiderman. Written by a physician with many years of experience as a medical ethicist, this book reviews some of the current issues facing individuals receiving health care in the United States. Dr. Schneiderman makes the case for embracing our mortality and educates us on how well medical decisions are made by individuals and those who care for them. The book is not specific to those with dementia, but clearly articulates ethical terms and conditions so that all sides of a complex medical situation can be evaluated. Hard Choices for Loving People: CPR, Feeding Tubes, Palliative Care, Comfort Measures, and the Patient with a Serious Illness, 6th edition, by Hank Dunn. This short guide, written by an ordained healthcare chaplain, covers common medical decisions encountered at the end of life. He provides brief statistics on how often procedures are chosen and what the outcomes are. He also provides different ways to emotionally or spiritually approach these decisions. 1. Understanding the end and the need for letting go. If you are listening to this book, you realize that your family member is moving to the final stages of dementia. More than 5 million Americans are living with dementia, a progressive brain disease that, as it marches to its final stages, means affected individuals will require more and more assistance from caregivers. But how do we know those final stages are nearing? And what does it mean for caregivers, not just physically but emotionally as well? Recognizing the end is nearing. The Kenny family story. My mom gave birth to 6 independently minded children, all with big personalities, a nice way of saying we do well when things go the way we see it, but struggle when they don't. Understanding that my mom's dementia had moved to the end stages came to my siblings and me at different times. My mom often didn't wake until 11 a.m., rubbing the sleep from her eyes, but quickly responded to coaxing and miming to put her arm out so we could put on her sweater, humming along with me as I readied her toothbrush. On a day like this, some of the Kenny kids would interpret Mom as doing great. Others realized that for this 1 hour of calm and cooperative dressing, she needed 12 hours of sleep. We recognized the probability that within an hour or two, Mom would offer only a blank stare. When she was able to focus, we recognized the mom from our youth and worried we were approaching her care from too negative a lens or missing some need that would unlock the path to full recovery. But gradually, one by one, we all saw that Mom barely spoke, coughed on a sip of juice, walked with less and less assuredness, and needed more and more sleep. As dementia progresses to final stages, affected individuals will require more and more assistance from caregivers. The staggering majority of caregivers are family and loved ones. Information on caregivers reveals several interesting facts. Most live with the
Sample complete. Ready to continue?